So first of all, a big thanks to Peter Ho and the entire organization team for putting together this fascinating conference and symposium. And I think yesterday's speakers have set an outstanding level for the talks, and I will try my utmost to live up to that. In the next 20-25 minutes, I want to share with you what, from our perspective, will be the way that the digital transformation manifests itself in healthcare and in medicine, and what are the risks and opportunities associated with that. So first of all, some not so good news. Yesterday we mentioned the future of medicine a couple of times, most of this in a rather optimistic way. Well, let's make a brief reality check. And the first lesson then is that we need to be aware at all times that healthcare as we practice it today is unsustainable. We have now slowly got it, almost all of us now, into our system that the way that we deal with our climate is unsustainable. And let's check the most important numbers in healthcare systems. What you see on these charts behind me are the healthcare costs as percentage of GDP over time. And as you see, they have been increasing steadily. What does this mean? We spend more and more of our money for health, and at the current levels, this is simply not sustainable. You also see that all the OECD countries more or less started around the same level of 5 to 7% of the total GDP in the 70s, but since then, especially the US, took off much faster than the rest of the OECD countries. And what this means is that in mid to long term, we either need to cut down on the quality of our healthcare services, or we need to cut down in our standard of living in other areas. Unless we become drastically better in doing health, there is no third option. Let me also quickly bring in the Singaporean perspective on that. Here the healthcare expenditures have also been growing. As a percentage of GDP, actually, they have stayed constant over the last couple of years. However, this is projected to change very much in the future. Why? Because Singapore is doing too well, especially also with the shift towards a more Western lifestyle. You get all kind of troubles that I will talk a little bit about today. What is the main driver behind this unsustainability? And that is the pandemic of non-communicable and chronic disorders. So they are the leading cause of death worldwide. And so with respect to yesterday, I have to tell you, in all likelihood, you're not going to live for 150 years. We will not manage to eradicate all diseases. You will not die in a zombie apocalypse or in a robot uprising. In all likelihood, you will die because of a chronic disorder. And the numbers, I think, speak for themselves. If we talk about chronic disorders, we talk about cardiovascular diseases, strokes, diabetes, and cancer, of course, and so on. Numbers from the Singapore Life Panel indicate that 1 out of 4 Singaporeans above 65 years will develop a chronic disease or developed a chronic disease in 2015. So this tells you how widely spread this problem is. How do we respond to the challenge? First of all, there was, since the 19th, the big hope that new cures will solve the problem. And of course, the main catalyst here was the Human Genome Project. And basically, some people still live in the mindset that by having access to the whole genome and being able with new technologies to edit the whole genome, we will get rid of almost all diseases. Well, this just means that the people who run the Human Genome Project did a very good job in selling this project, but the reality is that there are some specific diseases, some specific types of cancers where this kind of strategy works phenomenally. For others, not so much, and chronic disorders are mostly of that type where these things doesn't help. Again, some disencouraging numbers. What you see behind me is our attrition rates, the failure rates in clinical trials over time. And as you see, over the last 20-25 years, they have steadily been increasing, up to the point today where 95% of our clinical trials fail. That means we are very bad in developing new drugs, and we're becoming increasingly bad. A consequence of these high failure rates is that it becomes very expensive to develop new drugs. We are now at the point where it costs around $5 billion to bring one drug from the first experiment to the market. And we are especially not good in developing these drugs whenever lifestyle and environmental risk factors are involved. And this I want to talk a little bit about later. The other way of how this challenge is currently tackled are so-called healthy aging initiatives. You see these things springing up all around the globe. And basically the idea is that to bring people to a more healthy lifestyle and by that mitigate or prevent these disorders. Another point that I will try to make in this presentation is that there simply is no healthy aging in this sense. This is the wrong leverage point. And the reason why people believe in this leverage point is because they don't have a systemic understanding of what the disease really means. And in order to tackle this challenge, we need a new vision for medicine, and I want to share with you what, in our opinion, this vision entails. So I've got a background in complexity research, and coming from that, diseases are one of the prime examples of what a complex system comprises. Especially if we look at chronic disorders, so again, think cardiovascular diseases, think diabetes, think cancer. The hallmark of them is that they have many different risk factors that reside on many different levels. So let me give you a concrete example. Type 2 diabetes, we know about 30 genes involved in type 2 diabetes. Now, assume we could have the technology to edit all these 30 genes, repair them. How much of the diabetes prevalent cases could we prevent by that? The answer is about 10%. The rest of them have nothing to do with the genetic background of the patients. It has mostly to do with that people are fond of poisoning themselves with high dosages of fat, alcohol, and nicotine. And the same goes for a wealth of other disorders. If we talk about obesity, there it has been shown that the social network is a risk factor that is 200% stronger than the genetic background. So all these disorders have a strong social perspective, and in order to prevent them, we need to tackle them not only on the genetic level, but also on the level of social networks, on the level of metabolic pathways, and up to the institutional level. And each of this level can be quantitatively and data-driven studied by using data. And this is our vision for what medicine is. It is about managing these kind of networks in order to prevent and cure diseases. Let me say that this is nothing new. Medicine was always about these networks. Medicine is currently about these networks, and medicine will always be about these networks. The thing that is new today is that we have, for the first time, the data and the computational power to analyze these kind of levels quantitatively. And I'm not going to torture you with the amounts of data that we have in our hand. I just want to make one point by citing the former president of the Santa Fe Institute by saying that big data without big theory is bullshit. Whenever someone tells you something different, stand up, leave the room, you're being bullshitted at. And in order to tackle this challenge, what we need is big theory, big advantages in how we transform this data into knowledge. And this is where complexity science comes in, since it offers some tools in order to tackle these challenges. And I will now be indulging for a couple of slides in a couple of networks picture. Please stay with me. We do this exercise in order that you understand why this imagination of healthy aging is just that, a black elephant which is not really there. And for this, we need to understand the systemic nature of this challenge that we face. So what I'm going to show you is based on hospital data from Austria. Basically what we do there is, for billing purposes, we record for each patient when and for which condition he or she is admitted to the hospital. And then we can look at if a person comes because of, say, diabetes, what is the risk that she will also come due to pancreatic cancer. And by measuring how often these two diseases coincide, we can construct a network of diseases. So in what I'm going to show you, you will see bubbles and lines. The bubbles, the nodes, will be disorders. Size of them means how often they occur in the population, and we link them if they typically co-occur in the population. First, this kind of network, of course, strongly depends on the age of the underlying population, and it strongly depends on sex. And to allow me a short digression, we talk about individualized and personalized medicine, but the reality is that we not even fully understand the differences between diseases in males and females. So that should be the first step in going to personalized medicine. Anyhow, if we look at patients aged 0 to 8 years, those are their disease networks. So again, the points here are disorders. The size means many people have got this disorder. We connect them if they co-occur. And the color means in which part of the body they are affected. So for example, at this young age, we have mostly infectious disorders. Those are light green. We have diseases of the respiratory tract, mostly problems with the tonsils. And we can now trace how this network develops over time. These are 9 to 16 years. You see it gets a bit sparser. People are overall healthier. There is one cluster of disorders. Those are mental and behavioral disorders, including substance abuse. And this is the most prevalent health problem in this age group. Otherwise, these kids are rather healthy. Let's jump a bit forward, 33 to 40 years. And here you see well-defined classes of diseases of the same color. So those are the mental disorders in dark blue. You see a cluster of uterine disorders for females, not for males. Digestive disorders in red. And the first occurrences here of cancers, breast cancer for females, prostate cancer for males. What this tells you is that if you have a digestive disorder, your risk is very high of having another problem with the digestive tract, but that you have at the same time, say, a mental disorder, this risk is very low. Now let's keep this in mind as we trace how this changes. If you have led an unhealthy lifestyle, payback time is around 41 to 48 years. Now the metabolic syndrome kicks in, dyslipidemia, overweight, hypertension. As a consequence of this metabolic syndrome, cardiovascular disease and circulatory diseases spring up. And if we come to patients 65 to 72 years, this is how this network looks like. As you see, it's become a hairball. There are some disorders that span the entire network. What are these kind of disorders? It are, yes, you've guessed it, those are exactly these chronic disorders that we've talked about. And this is the big risk associated with this disorder, that they serve as risk factors for a large number of other health problems. And those are, which will bring you into the hospital, and those are that shorten your lifespan. So, the other thing I want to remark here is that healthy aging initiatives start to act on patients aged 65 years and older. Here you have already lost the battle when the population looks like that. So let's take a couple of things away from here. First, disease risks are predictable. And what we have shown that about 85 to 95% of the disease incidences can be predicted based on such an analysis. And now we need to talk about how to prevent and manage them. And before I give you some concrete examples of what we'll see in this line in the future, I want to give you the cartoon of what we are doing. And that is this here. If you know these underlying networks, if you know what causes which disease, we can optimize prevention strategies. And for example, find a root disorder that is easy to prevent in order to prevent other disorders that may spring up later and are hard to prevent. So this is the cartoon. Let's go into the concrete examples. This is work from Peter Sloat of the NTU Singapore, who has done a fantastic project on studying HIV and modeling the disease on levels ranging from the immune system over protein folding up to the epidemics level. And the main outcome here is that they found that in large social cities, social policies outweigh the benefits of medical improvements. And this is a direct nature of the systemic property of disorders, that it's often too reductionist to only consider the genetic level. For some cases, actually, the social policies might be the best mitigation strategy, and this you can work out using computer models nowadays. Since we are very bad in developing new cures, what pharma companies are trying a lot is to sell you an app together with the pill. And so this is an example from a group in Harvard that use a complicated sensor that we choose to voluntarily carry around with us, namely our smartphone, in order to monitor mental health. And the nice thing about this example is that it shows that you can use this in two different ways. So on the one hand, so what they do is they try to track the depressed state of patients moment by moment in vivo. And one thing that they do is that they give you a questionnaire that in a sort of gamified way asks you about the current state. And by this, and by responding to this questionnaire, they can track the current severity level of your depression. But the other thing is that this kind of sensor gets access to all kind of other data, like if you get called, how likely are you to call back? If you experience an episode, this probability goes down. How likely are you to leave your house? So talking about microchipping humans, that's rather a complicated way to go about this, to implant a microchip in brains in order to measure neurochemistry, just measure if the person returns a call or not. This is another work from a group in Colombia, and what they did is to go through adverse drug events, through reports of adverse drug events that are created automatically in the Stanford University Hospital, and to look at what do doctors report, which kind of adverse drug effects do they observe, to link this up with biological and molecular biological databases, and to see if there is some indication for adverse drug events. And by this, they have established a fully automated pipeline that gets you from the adverse drug reports that doctors make in the hospital to newly validated drug interactions. And speaking about the healthcare system as a self-learning system, these are the kind of things that we can expect in the future, these kind of systems that use this routinely collected data that healthcare systems produce anyhow in order to gain knowledge out of them. The guy who did this research, Nick Tartanetti, he's a computer scientist, and he's now to run mice experiment in order to validate his newfound relations in the lab. And he told me when he started computer science, he wouldn't expect that he will end up doing mice experiments. But this is the current state, that this kind of data science approaches have in some respects overtaken the normal clinical or the classical clinical approaches to medicine. And now I want to shift the focus a little bit and go onto the organizational level, where we view the healthcare system as a whole. And here we are using, again, network theory in order to understand how healthcare providers coordinate themselves in caring for patients. So what you will see now is a network where the nodes are not diseases, but doctors, general practitioners, hospitals, specialists, and we link them if they coordinate themselves in the treatment of a patient. And why do we do that? In order to improve healthcare management. We want to understand which kind of patient flows do we observe that are reasonable, and which make the system more or less efficient and more or less sustainable. So again, a cartoon. What we would maybe imagine is that a treatment looks like this. You first go to your primary physician. He or she sends you to a specialist. Then you go to the pharmacy, pick up your drug, and your contacts with the healthcare system are over. Maybe a more realistic example looks something like that. You first go to a primary physician, get sent to a specialist, different specialists, go to the pharmacy, nothing works, you try a different primary physician, different specialist, different pharmacy, adverse drug event, you end up in the hospital, misdiagnosis, different hospital, and so on. If you look at, for all of Austria, which are about 8 million patients and 20,000 doctors, this network looks more or less like that. And by knowing the structure of this network, we can now apply the tool sets that we have acquired in understanding critical infrastructure systems like power grids or like transportation systems in order to study how patients flow through the system and to ask questions of what are bottlenecks, what are choke points in the systems, how resilient is the system, and so on. And in order, what you have to do is that you have to geographically embed the simulation tools. This is one of the snapshots of how this might look like. And then you can start to add certain type of healthcare providers, remove them, and study what happens to the health state of the population if you restructure a healthcare system. We talked a little bit about how do we communicate our findings to the outside world. Working on such complex models, this is certainly a challenge also for us academics to get people, decision makers in health, to understand what these kind of models are, to get them to understand what these kind of models can do. And our response to that would be that we try to provide them with an easy-to-use interface where they basically can interact in real time with this model. If you sit in front of this tool and if you start to click around, let's add some doctors here, let's take doctors away there, let's assume this hospital becomes inoperational, how do the patient starts to move around, then you can do scenario modeling on your own without our involvement as scientists. And this is a direction where we need to take this kind of efforts. Another thing that you learn from these networks is how do billing and prescription practices depend on this network structure. So what you can do is you can basically use this as a way to benchmark the individual doctors, which kind of services do they bill, with which intensity do they bill, and does this depend on the health state of the underlying population, or do they just adapt their behavior to match their colleagues? And using this kind of tools, you have a data-driven way to identify inappropriate billings, and these kind of methods are currently developed all around the globe in a number of countries. The last point that I want to stress is to talk a bit about the risk side of this all. We briefly mentioned yesterday the point of when we talk about data privacy and data breaches, one of the central questions is who owns your data? And the same question holds here for the health sector, who owns your health data? Currently it's not you, let's say that as much. And this creates some kind of risks which maybe are not yet on everyone's radar. Well, so first of all, I think we don't need to talk about the cybersecurity aspects here, because first, they're not specific to healthcare, and secondly, they are not really new. And maybe what is specific to healthcare systems is that in the network systems, you have embedded pacemakers and CT and MR scanners, and you don't want to get these medical devices hacked. But despite this, there is not that much new there. However, a different kind of threat that where we see the first stimulus for that is that people use, or companies use this health data to game the system. And let me give you a concrete example. And this can be summarized as, sorry, I see something went wrong with this slide. But basically what I'm going to tell you now is if you have access to health data, how you can become a millionaire in 3 simple steps. First step, you identify rare diseases in the population. So the case numbers of some rare disease. Why does it need to be a rare disease? Then the chances are high that it is only treated with a single drug on the market, that there is no generic version available of this drug, and that the patent has expired on this drug. And then the only thing that you need to do is to acquire the rights for this drug. Basically, you can set the price as you want because the insurance will pay anyhow. If you are from the US, you are most likely aware of this example. In this case, the rare disease was AIDS-related toxoplasmosis, a complication end-stage AIDS. The drug was Theraprime, drug from the 50s with an expired patent, and the price was changed after acquisition of the supply chain of this drug from $13.50 to $750 overnight. And the only thing that was remarkable about this is the speed at which it went, because there they changed the price really overnight, and there is evidence that pharma companies are doing this on a much smaller scale, but are nevertheless doing this, and which raises the issue, how should you price pharmaceuticals? Should you base them on value, and how can you define this value? And all this comes back to the question, who should use your health data for which purposes? And with this, I'm at the end of my talk, and I want to summarize a couple of conclusions here. The first is that the opportunities in big data lie therein that we can now describe healthcare systems as holistic ways, as complex systems, and to incorporate all this kind of different levels and going beyond this reductionism of just looking at the genetic level. And at the same time, this allows us also to revolutionize healthcare management, and in particular through the formulation of personalized prevention strategies and the data-driven management of healthcare processes. And with this, I thank you for your attention.